4 centimeters, but no, 3 and maybe 2. I have one photo with a pen, and just the head of the pen, the head of the pen is 1.5, 2 centimeters, because you can make this like a moving window. You can put the skin up and down, and as my patients are very young, their skin are very good and very mobile. So small incisions. And it doesn't matter if I go with the plate from inferior to superior, from superior to inferior, what seems easier in the moment.
And you are not worried about any soft tissue interpositions, which you cannot see?
What I do is before I establish the 2 incisions with the C-arm, with the arm over traction, with some folds here, and always over under that traction, I pick up a methylene blue or a surgical pen, and I mark the incisions under C-arm control. I put the plate over here, always the widest possible. Nowadays, I only use 12 holes, non-locked. Locking is not a necessity, and I slide them. But I connect both incisions with my 2 index fingers. So one have to touch the other, and I put them submuscular.
So you take periosteal elevator?
Sometimes yes, but with a towel, I don't know how to say in English, but a swab, and a delicate osteotome from up, from down, and as I always say, humerus is a mother, and a mother accepts almost everything. So I'm not sure about, I don't care.
But the radial nerve is not a friend.
I'm going to tell you something. I'm going to tell you something that I learned 7 years ago in the United States with Sumant Butch Krishnan, and then I use a lot. Identify and demystify the nerves. So I put here 2 homons, and I have done more than 60 cases. I always search for the nerve. I have never found it. But if you found, you isolate. If you don't found, forget. And that's it. And that's it. This is not lack of responsibility. I'm going to use the word in English. This is demythification. You don't have to make it a myth. My father is a 72-year-old orthopedic surgeon. He was always telling me in residency, son, don't look at the radial nerve, don't even look, because if you touch it, the head will fall down. And I have made 7 long dissections of the radial nerve with more than 10 centimeters in mid-shaft humeral non-unions. All the photos are here. And absolutely, and the day after the surgery, the patient was doing this.
Okay.
I have the videos here. So identify and demystify the nerve.
Yeah. Shekhar? Yep.
The peripheral nerves are just
Excuse
me. Before technique you are flexing with the exterior plate.
Yes.
You are putting the screws from anterior to posterior.
From anterior to
Posterior
posterior.
direction.
Yes.
And there is only possibility of getting the radial nerve behind, because you are not going to see or feel the radial nerve behind the bone, and you are putting the screw.
But
you are likely
I
to
put
injure
it, I put it very delicately. I put it very delicately. I put it, and I always use C-arm passing over here to guide me.
So because it's deep, you are up and down.
No problem.
The
You don't do
fracture
anything.
usually in the radial
No.
nerve.
And you see,
You're
from
not putting from
the
in
mid-shaft to the elbow, the nerve
will come.
comes
There is
more
one, it will come.
anterior. So the nerve is
Okay.
is not here.
All right. Yes, I guess what Sergio is telling, that if it is a fracture in the mid shaft, and that's where the nerve crosses from medial to lateral,
Yes.
but above that it is medial, below that is lateral. So if you go directly posterior, maybe there is less chance of doing that. Yes, Shekhar.
He's putting only 4 screws,
Only 4 screws.
just on the whole blade. That's it.
2 up and 2 down, and many people, when I started showing this in India, in the internet 4 years ago, so many guys were hammering me that I decided 2 years ago that we only show cases after full healing. So in the last 2 years, I wait 2, 3, 4, 6 months, a lovely callus, and then I posted the case.
Okay, Shekhar, yeah.
So we did a similar study in our institution where we did almost 25 cases.
Yes.
And we had one case where we had a wrist drop immediately after the surgery.
Okay.
And we opened it the same day,
Yes.
and the nerve was beneath the plate. It was not through, luckily no screw went through that, but the nerve was between the plate.
No, is it, was the plate anterior or posterior?
No, same, the anterior.
Anterior plate.
Now,
How long is the plate, how many screws?
no, it was a long plate.
Shekhar, but anterior plate cannot
No,
touch the
yeah. So, what, then we thought that what went wrong. So thing is that you have to be absolutely anterior, because what happens that if you use the long plate, it has a tendency to go laterally.
Twist, yeah.
And secondly, you have to keep your arm supinated.
This is absolutely true.
Yeah,
I
because-
always tell my residents, don't move, keep the traction, and I put some belts in the chest and some belts in the thighs let's say to lock the patient. And my one resident is always putting the elbow, the arm in absolute,
because
in maximum
If you are not
supination.
aware of that, and your arm is
yes,
like this,
because
then
much
the
Then-
probably,
arm
absolutely.
much probably,
keep it
Yes.
supinated.
That is a
And
And then you
possibility.
try to
Rotate
rotate
it in the
anterior.
case.
Yeah.
So hand must be like this all the time, all the time.
Yeah,
So if you
probably
put it
avoid
in,
malrotation of the thigh.
Yeah.
yes,
Yes, there is a question from the, second row, please.
For this individual fracture, if you individualize the technique and implant for this very fracture, interlocking nailing, if you do interlocking nailing
Yeah.
as they have done,
Yes.
is the ideal one?
Yes, yes, for this, yes. There is nothing, no problem with that. We are having only a different
The
perspective.
cuff too, that has problems too.
Yes.
That messes up.
I
the-
think the whole idea is you're getting a close reduction. You get a close reduction, it doesn't matter what implant you put.
No, there's a problem with interlocking.
There are two double-blind randomized studies, one from Canada, one from America. 40 cases in each arm, plating versus nailing. There are more nerve palsies in the nailing group, more non-unions in the nailing group. Both the randomized studies.
Exactly.
Both the randomized studies.
This is what I was telling.
Non-union is definitely higher, non-union is definitely higher in the nailing group. True.
yeah, but
Have you taken all type of fractures or only comminuted fractures? Because that is the difference. You see, here you would like to do because it's comminuted. So close procedure.
I just want to make a very fast comment. I had a lot of fights in my life with my father, but some things he told me, he's a very old orthopedic surgeon, but one thing he told me, I have never heard in my residency, and I think it's very important to me. Whenever you put a synthesis, it doesn't matter the tibia, it doesn't matter, remember that someday you may have to remove it. So if you, so I am a shoulder surgeon, so I cannot accept the rotator cuff as an approach. So you open it, you put a nail, it goes to non-union, you have to reopen it, and sometimes HO people tell you to put a reamer, and then in the end, in my opinion, you are reaming the cuff. Yeah?
You can do it from the bottom also. You can put the nails to the bottom also.
I know, but you see, what I'm trying to develop with a lot of success is a way to fix all the humeral fractures without touching the rotator cuff. This is my fight.
Right, done. Done. So, yeah, food for thought. So we'll move on to the next scenario, which is, oops. Yes, please. This is the last one, yeah, because I have to leave also. This is the last scenario. This is a 46-year-old male office worker who had a bad fall on the elbow, and this is an isolated injury. What do you do?
No, these are not good exercises. We need true APS.
True.
Another lateral scan.
True. Axial wasn't there, that's true. But this is again not my case, I have taken it from somebody. Here, there is a concerned doctor on whatever the documents he had. He decided to, because he's 46-year-old and because he's a dominant side, he went in for a fixation. And no wonder, he of course did a reasonably good job, good alignment, good placement of the thing. And but of course not everybody will jump to fix such fracture by open method. Why not? Why not? What's wrong with conservative treatment for this patient?
The results of the conservative is not
Yeah.
as good. You actually do mean to have a lesser than optimal result. and I would fix it, but I would not use the plate, I would do the minimal technique. that
Yes, you
showed.
told us about. What's wrong with the conservative method of treatment for this thing?
I tell you one thing, that
Yes.
the purpose of treating a fracture is to restore function, not get the fracture healed. We can
Yes.
get the fracture healed anyhow.
True.
Immobilization for 4 to 6 weeks. We do conserve fractures.
Mhm.
They have to be stable fractures.
Mhm.
I must have the guts to mobilize that patient on second week with pendulums, with active assisted exercise.
What are you afraid of?
Because stiffness, the capsule just goes shut. Capsule shut, everything waste.
Is that a big concern for somebody who's 40 or 46?
Big time.
Okay.
And one thing,
I don't
how
know.
do you ensure that the GT doesn't stay, it doesn't
Yeah.
come below the head?
True.
Wait a second,
With the
the
conservative
the
treatment?
greater tuberosity here is not in place. Is
True.
back.
Exactly.
What you, that's the common
This is a big thing.
Yes, here,
Yeah.
here.
This is a true
My
basis.
biggest
And
argument
the greater
for
tuberosity here is completely at the back.
And the greater tuberosity is there.
classification, this is a bad prognosis on
Yeah.
Merkel's classification.
Yeah.
I will never treat it conservatively.
True.
But who would get a CT scan done?
Yes.
In a 4-part fracture, always.
This one.
Yes,
Yes.
Yes.
This is an articular fracture.
always
Yes.
CT
Yes.
scan. I think that's the message which should go to the audience. If you're ideally even in 2-part, but if you're suspecting even more than 2-part, even
Get a
slight
CT.
suspect,
Get a
get a
CT.
CT scan.
CT scan.
Any articular fracture, get a CT scan.
And a 3D reconstruction.
And a 3D reconstruction on that. Okay, so that is what was done on this gentleman, and it was fixed there, but we don't have the CT or other views or X-rays there. So that's it really, that's what was given to me, and I have to wrap it up here, I think, yes, because we are leaving for next time. Thank you.
Thank you very much, Debashish. We'll break for lunch now, and if we can meet at sharp 2, what we'll do is, because some of the faculty really wants to go early, so we might just cut down the last session to just the training opportunities that the expert faculty have to offer. So we'll probably finish at about 3:30, maximum by 4 o'clock. See you at
Frame joint capsule, which is contracted and which leads to decreased range of motion. This is what I believe. It's either a primary or a secondary. Primary is idiopathic, we don't know the cause, and secondary it can be to anything. It can be to any intervention, it can be to any surgery, it can be because of any other features like diabetes, thyroid, systemic diseases, Parkinson's. You must rule out other differential diagnosis, osteoarthritis, subacromial bursitis, or a neglected posterior dislocation. MRI findings largely largely unequivocal, except a narrowed axillary recess. But I think it is a wise decision to do it, because we may encounter other pathologies while doing an MRI, and so we can rule out other diagnoses. So management restriction, the order is ER restriction, abduction, and then finally IR restrictions. You can use an MRI arthrogram. Conservative treatment is traditionally the gold standard. Treat the secondary etiology, analgesics, and range of motion exercises. They're all helpful. Steroids, chemical ablation of synovitis, principally usually given in patients who fail to improve within 3 to 6 weeks of physical treatment. Nowadays, there is a trend of deviating away from steroids. MUA, not my personal preference. Again, you can have complications like dislocation, other complications, and inadequate relief or inappropriate relief in most of the patients. And I saw a lot of patients who are dissatisfied with MUA done elsewhere. So coming on to the mainstay of the topic, the arthroscopic approach. Traditionally, it is a very feared thing, because most of the times we are not able to negotiate our scope into the joint, and we are causing a lot of cartilage injury by doing an intra-articular arthroscopy. There are reports of cartilage injury, reports of even scope breakages by surgeons doing a stiff shoulder. So difficulty in proteolysis and articular damage was a fear that actually deviates most of us arthroscopic surgeons to actually doing a arthroscopic release in these cases. Now the solution which has evolved over time is an extra-articular arthrolysis, which is safe, easier, provides a more effective arthrolysis, and it prevents joint damage. So I'll just like to present my technique over there. So I don't do a glenohumeral arthroscopy in my stiff shoulders. I straight away start from the lateral portal, do my subacromial decompression, subacromial arthroscopy. I switch on lateral portal as my weaving portal and use the anterolateral portal as the working portal. The first step here will be to identify the biceps tendon. Do enough anterior-superior clearance of the bursa. I will like to identify the biceps tendon into the groove. We'll identify the biceps tendon, follow it along the rotator interval up to the insertion of the biceps. So, and we'll use our probe to actually identify the biceps tendon. We'll hook onto the biceps tendon, release it up to the biceps insertion.
Ratmesh, is it possible to stop?
Yes, sir.
Can I interrupt you? How do you identify the biceps from outside?
Yes, sir. Yes, sir. There are one or two techniques described. When we are looking from a lateral portal, and our instrumentation is in the anterolateral portal, we'll just come on sliding onto the coracohumeral ligament anteriorly, and we'll just identify that spot, and we'll just do a little cautery mark with that. And deep.
We'll talk to you later.
Sure. So the next step will be to do a biceps stenotomy. I do biceps stenotomy in all the cases of frozen shoulder, and it usually does not retracts and it does not causes a Popeye deformity as far as these stiff shoulders are concerned, because it gets stuck up into the groove. I'll release the stump. So this is how I do a biceps stenotomy into the groove. So this is how I do a biceps stenotomy. By doing a biceps stenotomy and releasing the rotator interval tissue in front of that, I get quite a good space so that I can look into the joint through the lateral portal. I release the stump as well. So this is a tight rotator interval tissue which is released. Now I'll maneuver my scope into the joint, and the anterior band you can see here will be the superior glenohumeral ligament, which will be the forming the sling of the biceps. I release that as well. And usually in these patients, this rotator interval tissue is fibrotic, so you have to do use a bit of punches here and to release the tissue. Once you do that, you will see subscapularis right in front of you. So this is what you see. So now we make another portal, which is anterior portal, and this is the subscapularis that we see after an adequate debridement. Now this band is the middle glenohumeral ligament. You can release the band directly through the anterolateral portal, and as you release this band, you will see the anterior band of the IGHL just beneath it. So you just split it, and this another tissue that you see just on the back will be the IGHL, anterior band. So you release that as well, and you will see a good space. This tissue is IGHL. So, and you release the subscapularis anterior and posterior up to the coracoid. So you just get away the external rotation part. You get a good external rotation with that. So this tissue you see is the anterior band of the IGHL. So once you release the MGHL, you'll see the IGHL right down there. This is the subscap tendon. You release it from the front and the back. Most of the adhesions will be right here in this area. Once I release my IGHL, I'll just swap on my portals. I'll make anterior portal my wing portal. No, I'll make the anterior portal wing portal, and I'll do a posterior release with the posterior portal. So that will be a near to. So this is the release of IGHL band. I stop here, don't go inferiorly. And then I swap my portals, make the anterior portal my working portal, weaving portal, and do a posterior release. And by doing that, I can make close to 360 degree release in most of the cases. This is the posterior release. So by doing that, I can do this is again subscap. And this is the posterior release, finally. This is the posterior release. So that is all about arthrolysis that I was talking about. Discussions, please. This will invite a lot of discussion.
I have a question.
Sure. Sure.
Okay, and offer as a comment. Microphones. No?
Coming from there.
Mike, please.
I have a comment, and you said about the MUA, and I must contest it. MUA is one of the best operations that we can perform to these patients, which is much simpler, much safer, much quicker, cost much less, and the patients are delighted in recovery. The thing is that manipulation, like any other big things, is a black box. What you call manipulation maybe is not what I call manipulation. And the devil is in the details, how you do the manipulation. And we'll do a little exercise that you understand how we do manipulation, how it is safe. We do the manipulation using the Codman paradox. So we don't put any rotational torque.
You want to model?
Yeah, we will all be model. Yeah, I can do it on a model. Okay. So, stiff shoulder.
Yeah.
Stiff shoulder. We first do the examination. So we, usually the stiff at about 60.
Yes.
Make it stiff like to make other things.
No, don't go there. Okay. So what we do, the patient is supine. I put my hand and stabilize the scapula. I put my hand, stick that in the axilla. My forearm is actually supporting his arm, and with a very short lever arm, I do elevation. So in the line of the scapula. At this stage, I hear crack, and actually I'm here. I've torn the inferior capsule.
Yeah.
At this stage, he's in full external rotation. Okay? I'm not putting any torque. I'm just putting the arm down to the side. At this stage, what I'm doing, I'm extending. Once I had a small rent, it will extend. So I'm hearing crack, and the rent goes up in the front. He had already got full external rotation without me putting any rotation.
Sure.
Then I take the arm across the body,
To
crack,
release the posterior.
release the posterior.
Yes.
At that stage, he's got full internal rotation at that position. But sometimes it's not completely full, it's only 80 degrees. So what I do is, again, I'm not doing any rotation, I'm just bringing that in adduction, like that, and I complete the upper part posteriorly.
And it's gone.
Full range of movement. You don't get any damage inside. You tear the capsule around. Okay? Now, just for you to understand how it works, if you all stand up for a second, make sure that you have enough space to abduct. Enough space to abduct to the sides. Okay?
Interactive shoulder.
Yeah. Can you put something just to cover that, because I can't look.
Yeah, that's okay.
Now, put your hands to the sides and look, all your palms are facing your thighs and your thumbs are facing forward, yeah?
Yeah.
Okay. We'll do two maneuvers. Don't do any rotations. 2 maneuvers and look what happens. We lift the arms all the way up and then from this position to the sides. Okay? Where is your palms facing?
The ceiling.
No, down. Facing outside, and your thumbs?
Outside.
To the back.
Back.
We've done 180 degrees of rotation without doing any rotation. Okay? But the timing is important as well, okay? Put your hands again down here. Now we'll do the same exercise, but the other way around. Lift your arms to the sides, all the way up, and then down. Again, we are facing.
Sure.
But we did the other side of the circle, okay? Without doing any rotation. That's the Codman paradox.
Codman paradox.
Yeah. And we use this Codman paradox to do the manipulation without putting the risk of rotation or fractures.
What you say is that take it all the way up first and then bring it back.
And then just bring it to the side, you've done a rotation.
It actually rotates automatically.
Automatically.
Okay. And then
you can't go over it without rotation.
Yeah, without external rotation you can't go over it, yes. And then you take it out and then bring it up.
No, what I do with the manipulation, what I did here on on my great model is I support it, I go up. At this stage, it's easier to tear the inferior capsule. So I've torn the inferior capsule. He is now in full elevation. He is already in full external rotation. What I need to do is just to bring it down to the side, and I get the full external rotation. Okay.
Are you doing under anesthesia or sedation?
Under anesthesia and with the interscalene block as well. So full general anesthesia and interscalene block.
Those patients won't allow you to touch his hand. And
No, it's full anesthesia. It's MUA, manipulation under anesthesia.
So Dr. Lavi, you have a strong shoulder unit, and this is a big belief amongst orthopedic surgeons, arthroscopic surgeons of the shoulder, that it leads to a lot of complications. Fractures, blah, blah, blah. I haven't seen any.
But it is written in many books.
It's written in many
No,
books.
no, it's
But-
not,
but
no,
I-
it's
I'll
not
tell you.
because of this that is true. But I have written in many books.
Yeah, but
You see,
we might be getting all those references.
I have seen very esteemed surgeons doing the manipulation, taking the arm from here and doing the manipulation. And they say that they take it from here to have a short lever arm. That's for me a very long lever arm. Okay? That's why in the papers, in some papers and some books and some presentations, they talk about fractures. Because if you take the arm like that and do external rotation,
But see, the question is, manipulation under anesthesia is a general orthopedic surgeon's domain.
Yeah.
I think every orthopedic surgeon in India does it, even in a small hospital, in a small
But
setting.
he needs to do it correctly.
But even with incorrect manipulation, where are the complications? I don't see. I practice in Delhi. How often have I seen a fracture of the humerus in the last 25 years following manipulation done by anybody, anywhere around north of India? Never.
But we see a lot of poor results, sir. Most of the patients usually come to us with unhappy. They are usually unhappy patients. They don't have a range in sustained range post-operatively. You might gain a good range of motion immediate post-op, but usually it is not sustained. And usually these patients fall back with an unhappy
They need
result.
physio. They need physio afterwards. Like the patient that you operate on. Exactly the same. They need physio. I mean, I'm not saying that arthroscopic release is not important. It's important. But it has a role in difficult cases that you can't get with. It has a role in post-traumatic, post-fractures, post-cuff tears.
No, that's a very important point you made. This is an argument I have with my senior colleague all the time in the shoulder unit. Okay, because MUA does have a role, but it's in the early stages it will work well. But if you are doing it in the second stage or the later stages,
Second stage. That's when
like second and later stages, especially in diabetics, the recurrence rate is higher. So arthroscopy has its role in select patients. MUA has its role in select patients. So you don't have to be polarized in one side.
So what is the harm we do with arthroscopy? Just let me put it another
He
way.
gave the answer earlier, the cost and the trauma and everything else.
Post-trauma,
He gave the answer everything.
post-fracture, post-cuff repair, I will do arthroscopic.
That is second line role in shoulder.
If you do a randomized blind trial,
In
suppose.
diabetics, sometimes you try to do the manipulation, you can't get the full range of movement. Usually the external rotation that you bring the arm down and it goes down, and goes in. Down, and goes in. They have the very thick medial glenoid ligament.
Yes.
You can't really tear. These are the guys, I won't insist on manipulation. I do a gentle manipulation, doesn't work, I go in with a scope and do a release.
Now the flip side of the argument is that there are studies where they have manipulated the shoulder, put in the scope and had a look. Now that's a very good way of finding out if you have a
Sure, this is very nice.
And you find it torn
So you found 20% of the time there were lesions in the cuff, you have created slap lesions, you have created labral tears, you have created bony labral tears. And I had one patient of whom I'm more of an arthroscopic release person, but I do it only for select patients.
Sure.
Because I do it for very stiff shoulders where you don't even have any external rotation. at all.
Refractory to conservative
Yes.
management.
So that patient I couldn't put the scope in, so I manipulated her, then put the scope in. It took a bit of labrum with the bone off, completely off the anterior labrum. And I do the same technique of manipulation like you said. Now again, this other thing I have seen is that in my fellowship there were two consultants, one does arthroscopic release, one does MUAs. You talk to the physiotherapist, he says the releases fly,
Yes.
the MUAs walk. Okay. The second thing is that person who does MUAs was a very senior consultant, with 35 years of shoulder practice. He manipulated a patient. That patient came back to the ER 1 week later with a dislocated shoulder. and that's the first time he's seen one. But it can happen.
Sure.
Things can happen even
Well,
with
complications
arthroscopic
from
release.
one complication, you can't be.
No, no.
Complication may happen.
Yeah.
But again, and we did a study looking at cuff, the rotator cuffs, because we do ultrasound to all the patients. Rotator cuffs before and after manipulation.
And?
We took the study and we didn't have even one cuff there. Because some people stood up and even, people like Christine Gerber said, oh, you don't do manipulation because you tear the cuff.
Yeah.
And people throw in the air things without support. And it's oh, if Christian said it, I have to check because
Yeah.
I haven't seen
Because
even
we
one
can with it.
in all my career.
But have you scoped it?
we did the ultrasound on all of them. There was none cuff there.
Some of them.
Some of them I scoped after the. I mean, again, if I do my arthroscopic release, I usually do a manipulation first, and I go in. None of them had a cuff there. And I didn't see the disasters that people describe. Yes, you tear the labrum, that's fine, because that's part of the operation. When you do a release, you don't cut it from the bone, you cut it from the bone. You release it from the bone. I release it around the glenoid, 360. Well,
360.
I cut the labrum as well. So, I mean, okay, so the labrum was torn, but that's part of my operation. I did it deliberately. So, I mean, I don't see these
Other thing that
and
I
some-
feel is that
some-
every time it is arthroscopic oscillation, don't you think it has become more in vogue since the arthroscopy, just like slap tears?
Yeah,
We're diagnosing more and more slap tears because of arthroscopy.
Absolutely.
And similarly, since the more and more people are doing arthroscopy, shoulder arthroscopy,
And there's another-
more arthroscopic arthrolysis.
And there's another thing. It pays
Slap
more.
lesion is a
It
different
pays
story.
no, seriously, it pays more. So
Yeah,
our
exactly.
American colleagues will do that and not
Yes,
do another
that's it.
manipulation. It pays
It's
more.
not the slap tear. What I'm saying is,
And
Interestingly,
20% of the
most of the research about arthroscopic release was not from America, but Tim Bunker did it, and he doesn't get paid.
Yeah.
to do
No,
that.
well,
So
he
been very passionate
he's
about
doing,
it.
he was doing private practice as well.
Yeah, but still.
The 20%
And-
rotator cuff tears you are saying, which was seen after manipulation, probably those patients already had the tear and they were stiff with the tear.
That's
They
possible.
were-
That's a possibility.
That's a possibility.
That's what I'm.
Depends
Because we
basically on
looked
the
at-
clinical history.
We
Yeah,
looked
that's what I said.
prospectively
So I
and we
think,
couldn't find
the
one.
question
So
is,
another-
where you
another-
saying do you
Well,
found the
this
rotator cuff tear?
discussion will not end. I'm quite sure. That's where I started with.
Yeah.
And I have actually 10 more questions to ask, which I'm not going to ask it because we have no time. But the,
You can have it in the
But he has made a point, you have made a point.
I think I'm a shoulder arthroscopic surgeon and I'm a mini American surgeon because in India we are mini American. We are in private practice. We want to make money. Okay, okay, but still, I think this is one area where my rate of intervention has gone down, not up.
Yes.
I have a smart physiotherapist. Every time I want to tell him now, this is the case I'm going to do surgery. I give you 6 weeks. He comes here after 6 weeks, no surgery required. So I'm quite amazed that this fellow actually fails me all the time. I'm quite happy with it, but I make less money. So I think there is a scope for a lot of conservatism, even manipulation, anesthesia. But I must tell you, especially the beginners, the case that you will get first time to do arthroscopy is a frozen shoulder. That's the one who is willing to get arthroscopy done by you. And it is the most difficult surgery to do arthroscopically.
Sure.
So you have a combination of easily available case, but a bad surgery, and you can actually do a lot of harm.
Sure, but
No, just in my series, there was no complication with this technique. Anybody who is doing this technique can have any complications with an extra articular technique.
No.
Sergio, please.
No. I just think that it would be important for the audience to understand that
It's a complication-free
that
technique.
arthroscopic or surgical management of frozen shoulder is an exception. It's not the rule. The rule is conservative management.
No, I'm disagree
That's right.
with that. It's not conservative. I mean, these guys will be, after 3 years, there will be more, the majority will be fine. But why to suffer for 3 years? And if you do MUA or arthroscopic release, I mean, in my hands mostly in MUA, and I'm an arthroscopic surgeon. I mean, I like arthroscopy and I do arthroscopy. I do crazy things with arthroscope. But I think you have to use it when you
Just,
need
yes,
it.
Let me
that's
ask you this
sure.
question. You must have done the conventional arthroscopic releases.
Yes, sir.
What made you go to this? It looks a little different. It's
Yes,
difficult to
yes.
me.
It's easier. Number one is I don't manipulate my shoulders. Usually if you have to do a arthroscopy with a traditional technique, you have to manipulate, because if you don't manipulate, you don't get enough space. You will damage the joint. you damage the joint, you can break your scopes, you can break your instruments. So, and I don't go into the subacromial, into the joint at all. When I do this technique, this is a pretty simple technique. You just have the feel of you should just have a feel of doing a subacromial arthroscopy. And if you can do that, if you can open the rotator interval, if you are able to look on the top, and if you are able to do all the releases, you don't have to do any manipulation at all till the end of the procedure. I do it at the end of the procedure.
The glenohumeral cartilage.
Yes, there's no damage.
You don't damage it with arthroscopy as well. I mean, if you have a difficulty to get in, usually.
But this is what I feel. This is a complication-free technique. You don't manipulate at all.
You can get the scope always facing towards the interval. And then you start to work from there.
So I think we can close, and I can have the privilege of making a final comment that in case sometimes you're not able to get into the joint through a conventional approach, I would actually think of this. Sometimes you're trying and you can't get in, and you know you're hitting the bone all the time. So you have to think about this. Let me go the prescribed way.
So start doing one time. You'll do it every way. you'll do it in every case that you do.
Thank you very much.
You should start doing it once.
Maybe I'll start liking doing more often then.
Thank you.
Once you like doing something, you like to do it more often. Yeah. So now let me invite our next speaker. Is Kapil here?
I will do it for him.
Kapil is very fond of frozen shoulder release. He used to tell me that he is somehow very fond. I don't know. Do you know about his new love called release for frozen shoulders? He's trained with you.
Yeah.
But he does a lot of releases for frozen shoulder. Where did he get from?
You know, sometimes your kids go different ways, you know.
Okay, so let me say what you have to say about surgical tips for hemiarthroplasty, four-part fracture.
So this is a lecture that I got this morning. I just added a couple of slides, but so bear with me. That's I present for Kapil. The shoulder hemiarthroplasty for fractures. Again, we talked about decision making in fractures, the patient factors, the fracture patterns, and I think that's a very important slide. And there's many classifications, but I really like Hertel's classification, and actually that it clicked down to me in the last year when I heard him again and again and again and again. Because look, that's what I added to this slide. Because Ralph Hertel is not talking about fragments, he's talking about fracture lines. That if you ask your trainee when he's on call, and he calls you about a fracture, ask him how many fracture lines you have. Because you have the fracture line between the shaft and the tuberosities, between the head and the tuberosities, and in between the two tuberosities. And by saying that, you know exactly what you have. And this is really clicked to me in one of his lectures, and wow, I saw the light. This is, all the other classifications are difficult to communicate. So that's, I think it's a very important slide. So again, the risk of head ischemia with a dorsomedial metaphyseal extension of less than 8 millimeters, and all the specific fracture patterns of head split and all that. Fix or replace. And here he gave an example of a 67-year-old lady with this fracture, which again, fix or replace. And I think what he did is using this phyllos plate, and he fixed it, which seems to be quite a good result. Still, there's some fragment there. Again, this case I added is my case. Just did it last week. This is a head split fracture in a 50-year-old lady. Fix or replace. So what I did is a minimally invasive. I did an anterosuperior approach. Reduced the head. Closed. You just reduced the head. Put this bone graft substitute block, and did a suture fixation of the tuberosities, and then put the palm tree just to have a fixation of the shaft, because by doing the palm tree I restored the medial hinge there. Okay, I don't know if this will not go avascular necrosis, but if it will go avascular necrosis, A, some of the cases will not be painful, and B, we can still do everything. We can do a surface replacement, we can do anything we want, all the bone is there. So the indications are the Hertel criteria and Hertel classification, fracture dislocation, head split, and age. And again, I think all of that should come into consideration as we've seen that. The most important thing is the tuberosity healing, to get it in the correct height, and correct orientation. Again, to get that, we need to do it in a appropriate manner. And this is something that I tend to say, that shoulder replacement or hemiarthroplasty for fracture is a soft tissue operation. No matter what what spacer you have there, it's a soft tissue procedure. You have to get the soft tissue tension right. You have to get the tuberosities to heal in the right position. And again, if you do that, probably prepare first the drill holes in the shaft with the sutures, and then attach the tuberosities to the shaft and to each other. I personally don't use the holes in a prosthesis. I think that's it's unnecessary. There are sometimes a problem, because if you get it through that, and if the suture moves a bit, it can actually tear the suture. I tend to do the idea of closing the book, as we discussed earlier, to close the book around the prosthesis. And you can see that's what Kapil actually put here. The same technique as you tie the tuberosities to each other, and you tie the tuberosities to the shaft, and this is a good result here of the hemiarthroplasty.
There is a fracture.
Pardon?
There is a fracture at the base of prosthesis. At the base of prosthesis, there is a fracture.
Yeah. Okay. The first time I see this slide, so I don't know. Maybe he wanted to show something with that. Did he tell you anything, Sergio? No, I don't know.
This is artifact.
But that's again, this is actually, in volleyball, when you play volleyball, one player bring the balls up and you smash down. That's this is an elevation of the ball for the next talk on the stemless prosthesis. Okay, why not use a stem? Yeah. Okay, so the height, you may use instrumentation, but usually it's too cumbersome. The pectoralis major tendon, the distance from the pectoralis, again, some people use it. I know that J.P. Warner tend to use it and all that. What I tend to use is the tuberosities. So I want to bring the tuberosities to the right height, that will have some overlap with the bone inferiorly, and I know that, I feel the tension. But this is something that you can't really learn from books. It's something that you have to learn by assisting a surgeon and learning to feel the right tension. So you have to be able to move about half of the glenoid, and then the tension is right. Results. Again, there's a paper here from Journal of Orthopedic Science. 18 out of 33 cases with poor healing of the tuberosities. And Boone et al. Rotator cuff tear. Something non-operative treatment with hemiarthroplasty. Randomized controlled study, non-operative compared, no difference in terms of quality of life or function. And this is another one, that hemiarthroplasty versus non-operative treatment of displaced 4-part proximal fracture in elderly patients in a randomized controlled trial showed less pain in hemiarthroplasty group, accounting for a significant improvement in quality of life without a difference in range of movement. To cut a long story short, again, as we know, you can find papers on everything from all the sides of the rainbow. The problem with hemiarthroplasty for fracture, that you either get the excellent patients, they are superb, or you get the really bad ones. You don't get the middle ones. And you can't predict who will do really superbly well and who will do, and that's the problem. Again, the key to success is obviously patient selection. The patient should be motivated. Cement the stem, again, depends on what kind of stem you use, because some stems are made for use as cementless. And yes, if you cement the stem, make sure that you cement only the distal bit and not the proximal bit. Because I had to revise a case where the surgeon was so enthusiastic, he cemented the stem all the way around, and then, surprise, the tuberosity didn't heal, because the tuberosity will not heal to cement. So, suture the tuberosities, this is the key, and the height of the prosthesis, these are the key for success. Now, reverse shoulder arthroplasty for elderly patients, we talked about it yesterday a bit, and I think in elderly patients, again, this is maybe a solution as one operation to give them quickly return to function and a good, reliable result. And if you look at Hemi, as I said, will give you, if you look at a graph, will give you the bad ones and the excellent ones. And the reverse will give you a good ones as a whole. Okay? That's another case that Kapil actually put there. And this guy actually, it's acute fracture dislocation. This is, I think in all classifications, this will be for prosthesis. Is a 79-year-old, this guy. I did a stemmed verso on him, acute stemmed verso, and this is the guy 2 years down the line with very good range of movement, good function, delighted with his shoulder. Again, recently, in the recent years, there are prostheses that are designed specifically to deal with fractures because you want to have a good fixation of the tuberosities. Even with reverse shoulder, I would tend to repair the tuberosities again to bring the tuberosities back, because then I can secure good rotational movement, which are important. And you can see that, at least in the verso, this low profile here is really made to accept the tuberosities. This is hydroxyapatite coated, so this is meant to be cementless, to fix it cementless, but if you need to, you can put a blob of cement down the shaft and do that. So to conclude, try to fix most of the fractures. Consider hemiarthroplasty as soft tissue procedure and reattach the cuff and tuberosities. Version height tuberosity healing is key to success. Significant risk of tuberosity escape, and this is what we saw a lot with a stemmed hemi, with a hemi. And consider reverse shoulder arthroplasty. Thank you very much.
Thank you.
So you see, he's a good pupil. The conclusions were exactly as I would put them.
Yeah. Good student. So any questions from the audience? Tell me 2 tips about 2 important things. One is maintaining the height, another is maintaining the version. In your practice, what do you follow?
Well, I tend to go to about 30 degrees, but I looked at the glenoid. I want it to face the glenoid. So if you do a 30 degrees, usually you'll face the glenoid. Yeah. If you have to adjust it, you can adjust it, but you have to go with 30, and then you can adjust it to be just in front of the glenoid when the arm is in neutral.
Yeah. So at the time of trial, you put the prosthesis in and then rotate and see.
And then see, you actually plan to 30. And then if you need to adjust it, you adjust it. And then I take the diathermy, and I mark on the shaft where I want to put it. So I know when I put the real thing, that's the way I want to put it. Sure. The height, if the tuberosities are not really comminuted completely, you have the height of the tuberosities. So what I do is I put the prosthesis, and I want to bring the tuberosities to sit just at the level, so just a little bit lower than the head, and to have some overlap with the shaft, and not too low, and obviously not too high.
The cadaveric study by Robertson, 210 cadavers. Net average version was 18 degrees. That 30 degrees has come to us from somewhere, and we just accepted it. And this 3 weeks back, we initiated our first Indian cadaveric study. We have done 60 cadavers now, and you will be surprised with the amount of variation in
the variations between 55 and minus 10.
50.
Yeah.
And the Indian average again seems to be 21.
Yeah. It's the 30 degrees is because of the direction of the scapula on the chest. Not the.
No. But when you're putting the prosthesis in, when you take the head out and you ream it at 30 degrees, that means you put a 30-degree version.
Yeah.
So
no, you put it 30 degrees because what you want is the arm in neutral to face 30 degrees.
Robertson said that if you use 30 degrees, you'll be right in 40% of the patients. 60% you'll be wrong. And so some of these patients have done extremely well because you matched their version properly. If you're doing a 30-degree version for somebody who had a 12-degree version, that cuff tension is just not going to be there.
Well, that's why you have to adjust it according to the patient on the table. Yeah.
I know we have now done a fantastic job with the shoulder itself. You've got a good X-ray, you're happy with it, but the rehab is very, very important. Like you mentioned, it's a soft tissue procedure.
Absolutely.
So like you rehab your cuff, you need to rehab this. And there was a fantastic paper presented in BEST 2 years ago, last year actually, where they did a cadaveric study, where they did all these sutures with it tying down, and he put them into motion, cyclical motion. With a few movements, the whole fragments came loose, and your bone broke off. So it's very important to immobilize them like you would do your cuffs.
Yeah, that's something that actually we went through. We were taught by Nir to move them straight away.
Sure.
That's for probably for arthritic cases, not for trauma. For the trauma we've gone through, and there's I've been across the world now, it's well accepted. For trauma you have to wait until the fractures heals, because if you start to mobilize them too early, it will fall off.
Would that not lead to stiffness?
Pardon?
If you mobilize,
Yeah.
would that not lead to stiffness?
Well, what you do is you have controlled mobilization. Means that you keep them in a sling for 3 weeks, then you start with gentle pendular exercises just to get them not to freeze. Very gentle passive, and you only start with active after 6 weeks. Yeah. Okay.
Anybody else? Thank you very much, Alpo.
Welcome. It's Kapil, it's not me, it's Kapil. I'm just a messenger.
Thank you, Kapil. And you are speaking next as well. You're doing the next one.
I'm doing the next one?
That's reverse arthroplasty.
Yeah, okay.
So are you talking about reverse arthroplasty in general or only for trauma?
No, in general. Oh, sugar. Okay. So I'll go to the development of reverse total shoulder arthroplasty, and obviously we'll concentrate on this shoulder, which is versal disarmor disclosures. Cuff arthropathy is, we all know what it is. You can see the patient in front of you here. Severe cuff, massive cuff tear, actually superior migration of the humeral head, erosion of the undersurface of the acromion and the AC joint, very, very restricted, very limited in her range of movement, and we all know these patients. So the idea is to provide a fixed center of rotation relative to the scapula and try to convert the upward directed force of the deltoid into a rotatory movement and making the elevation possible. Now, in a normal shoulder, we have the rotator cuff that really act as the foot on the base of the ladder to allow us to pull the ladder. And when we lose that, we can't pull the ladder, so we need to reverse the anatomy. Now, we are now celebrating 120 years to the first joint replacement, which was a shoulder. Obviously, shoulders are always on the lead. And this is Emile Pean that did a shoulder replacement for TB. This lasted for 2 years, obviously. And this is a picture of Emile Pean, actually by his friend Toulouse-Lautrec. They both were very happily living in Paris in those days, and liking and both of them liked to eat well. And I'm not sure whether this is a picture of Emile Pean operating or eating, but it's so reverse shoulder is not a new idea. It's an old idea, and already in the 70s, the Kessel prosthesis was designed in London. Ronald Colbell in Germany had his prosthesis, or the Liverpool shoulder. But the center of rotation in all these prostheses was very much lateralized to allow for the function or better function of the deltoid. All of these actually failed, and failed because of the excessive lateralization of the center of rotation, and resulted in excessive torque on the prosthesis bone interface in the glenoid, and this actually created loosening of the glenoid component. And then came Professor Gramont from France with the idea of medializing the center of rotation and tensioning the deltoid rather than laterally, inferiorly. And this was successful, and it works. It works, but it works, and it gets a lot of popularity, and loads of these prostheses came out in the last decade or so. But there are concerns, and there's nothing for free. There are concerns because there's a very high complication rate, more than 30% in the big series, in the big centers. Imagine what it will be in a surgeon that's doing 1 or 2 a year. Fractures of the glenoid at the time of preparation, fractures of the humerus at the time of preparation or afterwards, dislocations, high infection rate, very significant reoperation rate. The paper from Pascal Boileau, 22% had reoperation for cuff teratropathy, and between 20 and 60% reoperation for rheumatoid patients and revision cases. The complications related to the humeral stem, the stem reverse prosthesis, 10 to 20% complications of periprosthetic fractures, disassembly, loosening, and all that, and 16 of intraoperative humeral fractures, and 24 intraoperative complications where 67% of them were related to the humeral stem. So this is nothing to really ignore. Another complication which is very common is the glenoid notching, and you can see here, you can see what happens here. We lost half of the polyethylene there, and in the French multi-center study by Christophe Leving, he showed that between 62 and 76% of notching appearing already in 2 to 3 months after surgery. And Luc Favard told us in Japan that this progresses to 88% in the long-term follow-up. So something to be concerned. And I can tell you that when I revised this case, I had no bone left at all on the glenoid. I had to reconstruct it from allograft. So you can see it here. So any prosthesis may fail, and the amount of bone that we resect here is quite large. And what we do if things go wrong or fail, as we discussed earlier, to take this stem out, this is an oil-coated stem, the old stem of Biomet. This is a nightmare. And this operation took me about 6.5 hours just to take it out and revise it. And so these operations may not have a reverse gear, and therefore they are not recommended for young patients that you may have to revise them in the future. And I think, again, we have to think about the patients as a journey, not in one operation. So 2 ways to avoid that is, one is to use a platform systems, and we talked about it here and there, I think, about the platform system. Does it really work? Well, in the minority of cases, if the first surgeon did it right, and the only thing he needs to do is to replace it, and even then, the height that you put a prosthesis for an anatomical prosthesis is different from the height that you have to put it for reverse. So there is inborn error in this concept. So yes, you may do it better, and maybe the companies in the future will do it better, but at the moment it's just a gimmick, I think, in my view. The other option is not to use a stem at all. So does a reverse shoulder need a stem? No, the answer, you know my answer. So this is the platform system, and you can tell this looks very nice on this brochure.
Yeah.
But the angle is wrong here. The angle is wrong. The height is wrong, because when you do a reverse shoulder, you have to take part of the tuberosity. So this doesn't work. It worked nicely on the paper.
Yeah.
The paper accepts everything. So we designed the Verso as a stemless prosthesis, and the design principles were following Leonardo da Vinci. Simplicity is the ultimate sophistication. Keep it simple. Now, it's minimal bone resection. We resect only 20 millimeters of the bone. It's a stemless metaphyseal fixation, cementless. We use bone graft impaction, so we use the bone that we remove here. We don't throw it away, we recycle it. We impact it into the bone, into the humerus. It's a simple prosthesis, very simple surgical technique. The less steps you have to, you can make less mistakes. And we try to avoid the notching by, if you look at here, this is how nature wanted the delta to be when I revised it. So that's the way we give it. So by doing this dialable 10 degrees liner, we clear the space here, and therefore you'll get less notching. We didn't change the depth of the prosthesis. We changed only the angle to 145 degrees. Okay, and this gives us as well, because we remove some of the plastic here, better rotational movement, which are very important to these patients. And now we have, I mean, this is a paper presented in the IOAS and in the American Shoulder and Elbow Society. It's 2 to 7 years of follow-up with these prostheses. We had, between 2005 and 2010, 98 patients, the majority females, age between 38 to 93, the majority in the 70s, and 17 of these cases were revision arthroplasty. The majority were, 16 of them, of surface replacement, 1 of a stem prosthesis to a stemless prosthesis. Looked at the constant score satisfaction and radiological assessment. As you can see, the majority were cuff arthropathy, but we had rheumatoid and fracture sequela and other with irreparable cuff repair or failed cuff repair. You can see the most of the patients were very satisfied with a shoulder, with a patient satisfaction improved to 8.5 out of 10. Look at this lady, look at her rotations. I mean, elevations you get, but rotations you don't get with the other stemmed implants, and she's got excellent rotations. Again, the constant scores here improved for all the different diagnoses. Again, look at this chap on his rotations, not only the elevation, but he's got excellent rotation, external rotation and internal rotation. And if you think about it, what patients need most is rotation, because how much they need to get to the upper cupboard, but they need to get to the backside to take care of their own hygiene, or to get to the mouth or to the head, and this is important. So some patients that don't get that are dissatisfied with